Hello, my name is Mary Kate Saito, and my presentation is on oppositional defiant disorder. Oppositional defiant disorder, or ODD, is considered one of the disruptive behavior disorders and refers to a recurrent pattern of negative, defiant, disobedient, and hostile behavior toward authority figures that persists for at least 6 months. ODD has a cross-national prevalence ranging from 1 to 11%, with an estimated average prevalence of about 3.3%. Depending on age, ODD is somewhat more prevalent in boys than in girls, but then as age progresses into adolescence and adulthood, researchers haven't found consistency in that male prevalence. According to the DSM-5-TR, the diagnostic criteria for ODD is broken down into 3 main categories. Anger and irritability, where an individual often loses their temper, is often easily annoyed, and is often angry and resentful. Argumentative or defiant behavior, where the individual often argues with authority figures or, in children and adolescents, with adults such as a parent or teacher. The individual often actively defies requests from the authority figures or with rules, often deliberately annoys others, and often blames others for their mistakes or misbehaviors. And finally, vindictiveness, where the individual has been spiteful or vindictive at least twice in the past 6 months. Note that diagnosis would be at least 4 of these symptoms lasting at least 6 months. Many of these sound somewhat normal behavior depending on the age of a child. So for ODD, such behaviors should be considered that are outside the normal range for the developmental stage, gender, and culture of the individual. For instance, for the diagnostic criteria on the previous slide, for young children under the age of 5, it would be these behaviors occurring most days, but for older than 5, it would be occurring at least once a week. Moreover, to distinguish from normal range of behavior, the disturbance in behavior for ODD would be that which causes distress in the individual or those in their family, peer group, or work colleagues, or impacts important areas of functioning such as social, educational, or occupational. Severity is considered mild if only in one setting, moderate if present in at least 2 settings, and severe if present in 3 or more settings. There are 2 main subtypes of ODD, irritability and defiance. The irritability subtype is associated with internalizing problems, and researchers have found it predicted a higher prevalence of anxiety disorders. The defiant subtype is associated with externalizing problems, predicted in higher prevalence of substance abuse disorder symptoms. There is substantial comorbidity between ODD and attention deficit hyperactivity disorder, or ADHD, and is estimated at 30 to 50%. There are 2 models to understanding the comorbidity of the 2 disorders: the correlated risk factor model and the developmental precursor model. The correlated risk factor model has both ODD and ADHD sharing the same risk factors, while the developmental precursor model has that ADHD leads to ODD. Research into ADHD and ODD has also shown that individuals with these 2 disorders, especially boys, are more strongly linked with both bullying and victimization. ODD has both genetic and environmental causes. For instance, twin studies have shown that ODD has significant genetic influence. Environmental factors may include family, for instance, parenting style, and situations outside of the family, like school or work. Other studies have shown that gene-environment interaction depends on the subtype of ODD, where in the externalizing defined subtype, is more genetically influenced than the internalizing irritability subtype. Researchers are beginning to show that different interventional approaches may be more effective depending on genetic makeup of the individual. Treatment options for ODD include both psychosocial management and pharmacotherapy options, with parenting practices being the easily approachable target in the management of ODD. Other psychosocial treatment options include teacher training, peer group support, social awareness and supervision, cognitive behavior therapy, and functional family therapy. Pharmacotherapy options can vary depending on severity and subtype, and may include methylphenidate, atomoxetine, guanfacine SR, and clonidine. For more severe cases with aggression, antipsychotics or mood stabilizers may be used. Thank you.